thank you so much to the organizers for inviting me to see an honor and a pleasure for me. Talking to you today about one of my favorite women in bleeding disorders and the challenges that they face. I have research funding at Bayer. Perhaps importantly, very important to me, to use inclusive language when I can. I want to, and not all people who menstruate are women, a safe environment, and try to consider each patient's function. And I hope to create.
Paula, you're breaking up quite a bit. Maybe you want
a safe for this presentation today as well. This is a learning curve for me. So if it continues to be a problem, let me know and I'll hot. Okay. So I'm going to start with a clinical case. This is a very common patient that I see in my clinic. 36-year-old woman presents with heavy menstrual periods. She has monthly periods. The bleeding lasts 8 to 10 days. The heaviest bleeding is on days 2 and 3. She very commonly has flooding, accidents at work, and has been iron deficient since she was a teenager. In terms of her other bleeding history, she had to return to the dentist after wisdom teeth extraction because of excessive bleeding when she was 14 years old. She bruises easily, her gums bleed. There's no family history of a bleeding disorder, but she tells you that she sought medical attention for her periods and was told that they were normal. And I'm going to show you that this is in fact distinctly not normal. But unfortunately, that response is quite common. So heavy menstrual bleeding is a common problem. And depending on the literature that you're looking at, somewhere between 30 to 50% of all individuals who menstruate report a problem with heavy periods at some point during their reproductive years. And we recognize that this is the most common presenting symptom of an underlying bleeding disorder. And in fact, fully 15 to 30% of individuals who present with heavy menstrual bleeding have an underlying bleeding disorder that's contributing to that symptom. The definition of heavy menstrual bleeding is over 80 mils of menstrual blood loss per cycle. Not the most useful definition, although perhaps a little bit more functional with the advent of menstrual cups and the ability of people to directly measure menstrual blood loss. But if we're looking for correlates that would indicate heavy menstrual bleeding, these are the kinds of things that have been shown in previous studies. So individuals who have to change sanitary protection more than every hour, individuals who struggle with iron deficiency or iron deficiency anemia, difficulty with soaking the sheets at night or flooding upon standing, and periods that consistently last longer than 7 days. All of those things are signs of heavy menstrual bleeding. And this is important because heavy menstrual bleeding has a huge impact on people's lives. It's the cause of 2/3 of hysterectomies that are done during the reproductive years. It's an important cause of iron deficiency and iron deficiency anemia, results in substantial school and work absenteeism, and contributes substantially to a poor quality of life. And if we think about individuals with heavy menstrual bleeding who have an underlying bleeding disorder, we know that those individuals really can suffer from under and delayed diagnosis. And so the World Federation of Hemophilia estimates that about 1 in 1,000 people worldwide has an underlying bleeding disorder, which means that in Canada, there's close to 38,000 individuals with a bleeding disorder. But if we look at the number of people who've been diagnosed, and one way of getting at that is looking at a national registry that's housed at McMaster University, there are about 8,000 people registered. And it's possible that there are individuals who have been diagnosed who aren't registered. But I think that there are probably tens of thousands of individuals here in Canada who have an underlying bleeding disorder who are undiagnosed. And I would hazard a guess that the majority of those are women. And in addition to difficulties with underdiagnosis, we see substantial diagnostic delays for women who can wait up to 15 years from the onset of bleeding symptoms to an accurate diagnosis of an underlying bleeding disorder. And that's despite there being a similar age when compared to males of the first bleed, and despite the fact that treatment requirements appear to be relatively similar between females and males. And so I think there are a number of barriers that contribute to this. Top of the list is a lack of understanding of normal versus abnormal bleeding, particularly when it comes to gynecologic and obstetric bleeding. There's a stigma against open dialogue around periods and around menstrual bleeding, around postpartum hemorrhage. I think we've historically not done a great job teaching medical and science trainees about normal bleeding. There has been a lack of resources, research, and tools. And one of the challenges here is that uterine bleeding is normal. Monthly periods, postpartum bleeding, to a certain degree, those things are normal. And so how do you distinguish between bleeding that's normal and abnormal? That's been really difficult. Another challenge for women with bleeding disorders is that the diagnostic tests are tricky and not widely available. And I think inadvertently, some of what's happened historically with disease classification and nomenclature has inadvertently been a barrier. And I'm going to talk about each of these points in a little bit more detail. But I want to just directly call out this issue as well. And I've kind of alluded to this already, but I want to explicitly call out the fact that I think sexism and a systemic lack of awareness and focus on women's health issues has definitely been a contributing factor here, and something that we need to be aware of and strive to improve. And so this is important to me because delayed or missed diagnosis results in missed treatment opportunities and increased morbidity. And I already alluded to issues with quality of life, but this is data that comes from an older Canadian study that actually shows that the quality of life in women with von Willebrand's disease, particularly those with heavy menstrual bleeding and iron deficiency, have a quality of life that is worse than a man who is HIV positive with hemophilia. And so the idea perhaps that men suffer more with their bleeding disorders, I don't think is an excuse for delays and underdiagnosis. So with that somewhat sobering intro, I do want to move on to talk more optimistically about how are these challenges being addressed and what can we do going forward. So I know many of you are familiar with work that's been done in the realm of bleeding assessment tools. Bleeding assessment tools are questionnaires that derive a bleeding score and quantitate bleeding symptoms. It's a standard way of taking a bleeding history. And bleeding assessment tools have been shown to be very effective screening tools for underlying bleeding disorders, particularly von Willebrand disease. And they've been shown to be quite effective at distinguishing between normal and abnormal bleeding. Many of us who run hemostasis clinics, women and bleeding disorders clinics, use bleeding assessment tools very commonly in our assessment of patients. And many of the tools that have been developed and validated are expert administered, meaning that a nurse or a physician or a research assistant asks a series of questions and based on the answers determines a bleeding score. A number of years ago, we were interested in putting a tool like that into the hands of the general public. And so developed and validated what we call the self-BAT, or the self-administered bleeding assessment tool, which is freely available on our Let's Talk Period website. And so this website was launched in May 2016, and I have been repeatedly impressed with the appetite for the kind of information we're providing here. There have been nearly 300,000 page views. Over 38,000 individuals have taken the self-BAT. About 40% of those have had an abnormal bleeding score, which is far higher than you would see in the general population. So certainly the site is attracting individuals who have bleeding problems. And just like with the expert administered bleeding assessment tools, the self-BAT has been shown to be a very sensitive screening tool, particularly in adult women for an underlying bleeding disorder with a very high negative predictive value. And so from a diagnostic accuracy point of view, a bleeding score works very well to try to determine who has abnormal bleeding and who needs additional testing for an underlying bleeding disorder. The Let's Talk Period website isn't the only site like this that's been developed. There are a number of other sites that I've highlighted on this slide. So an Irish a site called Helping You Better Know Your Flow. The National Hemophilia Foundation has a site called Better You Know. The Foundation for Women and Girls with Blood Disorders has resources that are freely available. And we are seeing an increase in scientific meetings that focus specifically on the issues of women and bleeding disorders, and programs like you've got today that have included these kinds of talks and discussions around these issues. So to move on to a discussion about lab testing, generally, when we see somebody in clinic who has heavy menstrual bleeding, we would start with a complete blood count and then general clotting time, so a PT, APTT. But an important point here is that those can be normal in somebody with an underlying bleeding disorder. And you have to go on to more specific testing that I cover lower on this slide. I also, for anybody who would be involved in the care of these patients or anybody who might be seeking medical attention for these problems, themselves, please make sure that a ferritin is checked, which is the best measure of underlying iron stores, because iron deficiency is really a significant problem in this patient population. So then to look specifically for bleeding disorders, you can see a list of assays that should be considered. Specific tests of von Willebrand factor or factor 8, testing of factor 8 and factor 9, as well as genetic testing if you're looking for hemophilia or hemophilia carriership, platelet aggregation testing and release for those who may have an underlying platelet function disorder, or other coagulation factor assays. As I mentioned before, these are tricky tests though. This is specialized testing that's not widely available. These tests are impacted by pre-analytical variables, particularly sample transport, shipping, and temperature, and I'll show you some data on that in the next slide. These assays require significant expertise to interpret, and there's a historic lack of agreement on diagnostic thresholds and nomenclature, although we are starting to make some inroads in that area. So this is a fairly recent publication from colleagues in the States, Julie Jaffrey, who looked at 263 patients from 17 centers and compared testing for von Willebrand's disease, the VWF antigen, VWF platelet-dependent activity, and a factor 8 assay. And the results of those assays within specific patients comparing off-site and on-site with normal results in blue and abnormal results in red. And you can see that the frequency of abnormal results off-site was much more common, and that In fact, less than 40% of individuals who had abnormal assays with the initial set of tests from an offsite lab were actually confirmed to have VWD. And so the conclusion of these authors, which I strongly agree with, is that VWF assays need to be collected and processed at the same site under the guidance of a hematologist or hematopathologist or other kind of lab scientist who understands the importance of the pre-analytical variables and how to interpret these results. I mentioned the issue of diagnostic thresholds. We did our best to tackle that with the ASH, ISTH, NHF, BWF 2021 guidelines on the diagnosis of von Willebrand's disease. And so there was a diagnosis and a management panel that were struck, and both of those publications were published in Blood Advances in January 2021. From the point of view of the diagnosis guideline, every diagnostic recommendation that we made prioritized not missing affected patients. In the management guideline, there are a series of recommendations that are focused on gynecologic and obstetrical bleeding, such as the use of prophylaxis in those patients with a VWF concentrate if necessary, how to manage heavy menstrual bleeding, what to do about epidural anesthesia, and then how to prevent postpartum hemorrhage. But really an important challenge facing us, those of us who were on these panels, was that out of the 23 recommendations that we made on the diagnosis and management of VWD, only 3 of them are strong. And that's because of generally low quality evidence in this field. And so I think as a community, we really need to put an increased focus on high quality clinical evidence to help guide the management of these patients. Another example of an initiative that's been undertaken to try to improve the care of women with bleeding disorders is a recently published paper on updated nomenclature for hemophilia carriers. And you can see that what was recommended in this paper is that for carriers who have low factor 8 or 9 levels, which happens at about 30% of those who carry one of the mutations for hemophilia, that in those individuals who have low factor levels, the diagnosis should not be hemophilia carrier. It should be a woman or a girl with mild, moderate, or severe hemophilia with the degree of reduction in factor level correlating with how we use that terminology in males who have hemophilia. And I just want to point out that the authors of this document recognize that where we need to go is person with hemophilia in terms of this nomenclature. There also in this paper is a category for carriers who have normal factor 8 or factor 9 plasma levels if they have abnormal bleeding, which again has been seen in about 30% of carriers, that the term symptomatic hemophilia carrier be used to reflect that those individuals can have abnormal bleeding and not just carry the gene that can be passed on. So just to return to the clinical case as I wrap up here. So our patient goes to see her family physician. She had taken the self-BAT and got a bleeding score of 7. If you're interested, please feel free to take a look at how that works on the Let's Talk Period website. A bleeding score of 7 in a woman of this age is abnormal. So she has an increase in her bleeding and abnormal bleeding phenotype. Blood work shows that her hemoglobin is 102. The bottom end of the normal range in an adult woman is 120. So this patient is anemic. She is microcytic, which is consistent with iron deficiency. And she has a ferritin of 8, which is also diagnostic of iron deficiency. As mentioned, her PT and APTT are normal. Her family physician is on the ball and up to date with management of heavy menstrual bleeding. So iron supplementation is started, and she's referred on to hematology. In the hematology clinic, because of the abnormal bleeding, specific testing for von Willebrand's disease is ordered. And you can see the levels of von Willebrand factor antigen and activity as well as factor 8. The bottom end of the normal range for all of these assays is 0.50 IU per ml. So there's low von Willebrand factor, activity and antigen, and just a borderline low factor VIII level. The VWF multimers are normal, and there is normal platelet aggregation and release. And so this patient is diagnosed with type 1 VWD, and a desmopressin trial is arranged. Desmopressin causes the release of stored von Willebrand factor from the endothelial cells and can be used temporarily to prevent or treat bleeding. She was started on tranexamic acid at a dose of 1 gram PO/TID. Tranexamic acid is an antifibrinolytic that's quite effective for mucosal bleeding. It would have been possible for the family physician to start this patient on tranexamic acid while she's waiting for the appointment in the hematology clinic. Tranexamic acid doesn't interfere in any way with the assays that need to be done for diagnosis. Follow-up is arranged in the gynae hem clinic. And 6 months later, this patient has significantly improved energy and concentration in periods that have decreased to about 6 days with lighter flow. And this is a very, very common scenario. Treatments are relatively straightforward in these patients and really help to improve the quality of life. So in conclusion, I hope I've convinced you that accurate diagnosis of a bleeding disorder for all individuals who have a bleeding disorder is critical. There is value in the use of bleeding assessment tools. We need to make sure that we're doing high quality lab assays, and we need high quality research on which to base our recommendations. But this is a wonderful group of patients to treat, and we have effective treatments that significantly improve quality of life. So I want to end by acknowledging the members of my lab and also the members of my Let's Talk Period team, as well as our funding agencies. So thank you so much for your attention. I'm going to stop sharing and turn my camera back on. I hope that came through okay. I'm happy to take questions.
Thank you very much, Paula. Looking for questions in the room here. Looks like Dr. Conway might have one.
If you're asking me a question, Ed, I can't hear it. So I still can't hear anything happening on your end.
How about now?
Hey, I got you now.
Hi, Paula. It's Ed Conway. I am. That was fantastic. There are some questions here, but let me start. First of all, it was a terrific talk. It's really interesting. Even going to your case, where the patient is ultimately treated with tranexamic acid, there are a lot of patients in the developing world where the challenges of making a diagnosis, and you've pointed out the challenges even here in North America and Europe, where it's so difficult, and where we have, and you pointed out you need sophisticated testing. So what are the steps one can take in reality today, not wait 10 years until we get not to mention sophisticated testing, but even simple testing. What do you do in the developing world?
Great question. So there was a fantastic talk about a year ago from Alex Srivastrava, who's a hemophilia treater from India, and he was talking about exactly this issue. And I liked his approach because he was being very supportive of some things that I've done. So he actually was talking about the use of the self-bat and making sure that there are cultural and linguistic translations that are appropriate. And we've started to work with other patient organizations to try to create those. But really, the identification of abnormal bleeding, tranexamic acid works well for heavy menstrual bleeding, no matter the cause. And so he was advocating for the use of a bleeding assessment tool and then perhaps genetic testing, and then going back to phenotypic testing if there's a variant identified. Now that's a little bit tricky for some forms of VWD where, you know, the genotype phenotype correlations aren't straightforward, but that approach certainly would pick up individuals with type 2 and type 3 von Willebrand disease. So the answer, I think, is really to focus on the symptoms and to treat the symptoms in the absence of being able to make an accurate diagnosis. What I think we see in Canada too often and happens in low and middle income countries as well is, well, there's nothing I can do, so I'm just going to completely ignore the fact that you have terrible bleeding. And I think we could focus more on the symptoms. There's also, as you well know, Ed, because you've been involved in this, but there also are initiatives to try to help improve the lab capabilities in low and middle income countries, and even getting some basic things going, like the ability to do a PTT, starting with a factor 8, that assay is more straightforward than doing the VWF assays. So trying to build incrementally. A ferritin is a very straightforward assay that is widely available and certainly would flag somebody who's in need of some kind of management.
Oh, is this working? Hey, Paula, it's Erica Crilly, the nurse practitioner from BC Children's. Just actually reflecting on what you were talking about, during COVID, it's been quite interesting because I think virtual care has been a wonderful way to connect with adolescents with heavy menstrual bleeding, because I think socially it's easier to talk to them, to be able to share tools and share the PBAC and some of the bleeding assessment tools has been wonderful. So I think virtual care actually has really ramped up the clinical care we can deliver to this population. But your comment on the lab tests being very difficult to do remotely, I think has been a very big challenge, especially in BC where our population is very scattered. My question, though, is I'm wondering if you have found that patients with iron deficiency have more bleeding problems, and once you've managed their iron deficiency, actually sometimes their heavy menstrual bleeding is mitigated.
I just love talking to people who see the same patients that I do, because there really are, we all have the same observations. So I'm currently on sabbatical in Toronto, designing a clinical trial to answer the question, exactly the question that you just asked. So Michelle Schultzberg and I are working on a clinical trial and the question is, does upfront IV iron decrease heavy menstrual bleeding? Because we have made the exact same clinical observation that you have made, which is that women who are iron deficient, particularly those who have anemia, but those who have non-anemic iron deficiency, in our experience, seem to bleed more. And you're well aware that usually the approach to iron deficiency is a trial of oral iron, and if it doesn't work and 30 to 40% don't tolerate it, then you move to IV iron. We're going to try to flip that paradigm in a clinical trial and see if we can come up with some evidence for exactly the point you just made. Maybe you could review my when I submit it.
Hi, Paula. It's Prysdale here, and thanks a lot for joining us. I'm going to ask you a little question, and then I'm going to ask you a question that Jill Johnson has forwarded to us by email. My question is just to make this a little bit more tangible. What percentage of hysterectomies do you think might have been avoided if we had gotten some proper diagnosis going on here? I mean, this is a serious issue.
It's a serious issue. I don't know that I've seen solid data on that, Ed, but it would be a lot. I mean, we know that heavy menstrual bleeding leads to 2/3 of hysterectomies in the reproductive years. I mean, I would bet half of that probably could have been avoided. So maybe a third. You know, there are far less invasive surgical ways if you end up with surgical management, endometrial ablation, Mirena IUD, that have been shown to be very effective for heavy menstrual bleeding. So I bet it's a significant amount.
This is an incredible problem. And Jill Johnson asks, and first she states, fantastic talk, and we all agree. She says she's interested in hearing your thoughts on evolving terminology. In genetic testing in the US, they have difficulty with the use of the term carrier, which in bleeding disorders often just equals biological female, but in the rest of medicine, particularly medical genetics, is defined as a person who is a genetic variant but does not have disease. So you started to touch upon that idea. Maybe you could elaborate a bit.
Yeah, thank you, Jill. And for those, I'm sure you all know who Jill is. Jill could have easily given this talk. Really a significant expert in coagulation and women with bleeding disorders, and a significant ally and colleague of mine. I think that the ISTH paper I referred to was kind of a start there, recognizing that women and girls can have hemophilia and advocating for that particular diagnosis, which patients have been doing for a long time. I totally agree that we have to get away from this idea of carriership as simply being a risk factor for passing on the gene, and continue to work to highlight the fact that a significant proportion of those women have a bleeding phenotype themselves, and calling that out and providing them with appropriate care.
Okay, thank you very much, Paula. That was just a fascinating presentation.